Good evening, everyone. How are you? Hope you're doing good. I am Dr. Sulthan and Rashid, Assistant Professor of Pharmacology from Savitha Medical College and Hospital, Chennai. I'm also going to complete my fellowship in diabetes mellitus course, which is accredited to Medvarsity, Royal Liverpool Academy, United Kingdom. So my special interest is to teach pharmacology related to anti-diabetic drugs. So today I am going to discuss about one of the important anti-diabetic agent, that is metformin. Let's go into the topic. So biguanides, metformin belongs to the family called biguanides. So metformin is the only member of the biguanide available today. So it is a class of oral hypoglycemic drugs which is available for use today. So what are the previous available biguanides which were removed from the market? There are metformin and buformin. Why they were removed from the market? We know the reason. It is because of lactic acidosis. In 1970s, because of unacceptable rate of associated lactic acidosis. So what is the mechanism of action of these biguanides, metformin? So several mechanisms have been proposed to explain the central pharmacological action of the metformin. Main action is the reduction of hepatic glucose production, primarily by inhibiting the process called gluconeogenesis. So glucose production will be inhibited. Although metformin also has a lot of specific actions on mitochondrial respiration. It reduces the intracellular ATP in the mitochondria and also increases the AMP. It reduces the intracellular ATP while it increases the AMP. So experimental evidence also supports activation of AMPK. Activation of AMPK, that is AMP dependent protein kinase by metformin. So after activation of the AMPK, it leads to stimulation of the hepatic fatty acid oxidation, glucose uptake and non-oxidative glucose metabolism, further leading to reduction of lipogenesis as well as gluconeogenesis. Metformin also inhibits the mitochondrial glycerol phosphate dehydrogenase. It can also change the redox state of the cell. So most recent evidence also implicating other mechanisms like including the blunting the effects of glucagon, inhibiting the conversion of lactate and glycerol to glucose, and shifting the liver towards negative lipid balance. So these are the additional mechanisms of metformin which have been discovered very recently. So most of these pharmacological effects of metformin are mediated in the liver, while in the skeletal muscle there is only little effect on glucose metabolism or insulin sensitivity in the skeletal muscle. Metformin has little effect on blood glucose in normoglycemic states, so it ensures that it does not stimulate the release of insulin or other isolate hormones, so it rarely causes the hyperglycemia. So in normoglycemic patients, it will not have any effect on blood glucose because it does not stimulate the release of insulin. However, even in the person with only mild hyperglycemia, metformin lowers the blood glucose by reducing the hepatic glucose production and increasing the glucose clearance. This last effect is not well understood because of the modest action of the metformin to promote glucose uptake in peripheral tissues like skeletal muscle and adipose tissue. And there is only very little information to support a direct effect of metformin on the hepatic insulin signaling. But there are at least complementary effects of the drug to improve the dose-response relationship between the insulin and hepatic glucose production. So what are the fixed dose combinations of metformin are available today? They are available in conjunction with other drugs like glipizide, glyburide. So these are sulfonylureas, pioglitazone, thiazolidinediones, repaglinides, meglitinides, rosiglitazone, pioglitazone is also a PPA or gamma agonist. Linagliptin, saxagliptins, they are sitagliptin, alogliptin, they are DPP4 inhibitors. Canagliflozin, dapagliflozin, empagliflozin, they are SGLT2 inhibitors. So these compounds are in combination with metformin as available as fixed dose combination with metformin. So these preparations are available today. So based on the pharmacokinetics of we have a common immediate release form of metformin. It is now recommended for twice daily administration at the doses of 500 milligram to 1000 milligram, that is 1 gram. We can use the maximum dose we can use is up to 2550 milligram. But the therapeutic benefit starts to plateau at around 2000 milligram. So this is the immediate release form of the metformin. We also have a sustained release preparation is available for once daily dosing starting at 500 milligram daily with titration up to 2000 milligram as necessary. So regarding the absorption, Metformin is absorbed primarily from the small intestine with a bioavailability of around 70 to 80 percentage. The peak concentration of the oral dose occurs at about 2 hours later, and drug's plasma half-life is around 4 to 5 hours. The drug does not bind to the plasma proteins and is excreted unchanged in the urine. And the transport of the metformin into hepatocytes is mediated primarily by the OCT1, and the renal uptake is mediated by the OCT2. And export into the urine is by MATE1 or 2, that is called multi-drug and toxic extrusion proteins 1 and 2. So metformin is generally accepted as the first-line treatment of the type 2 diabetes mellitus and is currently the most commonly used oral agent for this condition. Metformin is effective as monotherapy and also in combination with other glucose-lowering medications. African Americans, they may have a better response to metformin than Caucasians, and metformin has superior or equal efficacy of glucose-lowering compared to other oral agents used to treat diabetes mellitus. It also reduces the microvascular complications in patients with type 2 diabetes mellitus, and there are also limited data which supports a beneficial effect to reduce macrovascular disease as well. Metformin does not typically causes weight gain, and some patients it also causes weight loss, causes mild weight reduction. In patients with impaired glucose tolerance, treatment with metformin delays the progression to diabetes. So other than diabetes, where we are using metformin, it has been used in the treatment of infertility in women with polycystic ovarian syndrome. Although not formally approved for this purpose, metformin demonstrably improves the ovulation as well as menstrual cyclicity, and it also reduces the circulating androgens and hirsutism associated with PCOD. So what are the adverse effects and drug interactions of metformin? The most common side effects, 10 to 25% of the metformin are gastrointestinal side effects, nausea, indigestion, abdominal cramps, bloating, diarrhea. We can also get combination of these symptoms. Metformin also has direct effects on GI functions, including interference with the absorption of glucose as well as bile salts. One of the important side effects of metformin is vitamin B12 deficiency. So the use of metformin is associated with 20 to 30% lower blood levels of vitamin B12. So we should always monitor the B12 levels very frequently. And most adverse effects of GI effects of metformin, they will abate over time with continued use. It can be minimized by starting at the lower doses and gradually titrating the target dose level. Over several weeks, we can titrate to the target dose. We can also avoid this side effect by having patients take the drugs with the meals. So you advise the patients to take the metformin with meals so that we can prevent these GI side effects. And most studies also indicated that extended release metformin preparation has decreased gastrointestinal side effects. It can be substituted for the immediate release metformin in patients who are having difficulty in tolerating this drug. So extended preparation is much better than immediate release preparation of metformin. The only concern is lactic acidosis. Let's talk about lactic acidosis problem. That's why the previous biconides like metformin and buformin, they are withdrawn from the market. Because of the previous available biconides, metformin and buformin, they causes lactic acidosis. Metformin also has been carefully scrutinized for this side effect. So lactic acidosis associated with metformin has been rarely reported in patients with setting of concurrent conditions which causes poor tissue perfusions like sepsis, myocardial infarction, congestive heart failure. The recent analysis have raised doubts regarding whether there is an association between metformin and lactic acidosis. So there is a lot of doubt in that, whether the metformin is producing this side effect. So if you see the patient with lactic acidosis associated with the metformin use, the most common comorbidity seen is renal failure. Okay. And the plasma metformin levels are inversely related to the GFR due to reduced clearance of the drug from the circulation. Inversely related to GFR means if the GFR is reduced, the plasma concentration of the metformin will be elevated. So the levels rise above the usual therapeutic range when the creatinine clearance drops below 40 to 50 ml per minute. However, in the recent studies of patients with severe renal failure, including some requiring dialysis, the rates of lactic acidosis were not increased in those taking metformin. The American Diabetic Association suggests that metformin can be used safely when the GFR is greater than 45 ml per minute, bar 1.73 m squared. And the dose should be reduced by 50 to 75% when the GFR is 30 to 45 ml per minute by 1.73 meter squared. So it is important to assess the renal function before starting the metformin, and we have to monitor the function at least yearly, annually. So in certain conditions, the metformin should be continued preemptively if the renal function could decline precipitously. For example, before radiographic procedures like use of contrast dyes for CT and during admission to the hospital for severe illness, you should discontinue the metformin. And metformin should not be used in patients with severe pulmonary disease, decompensated heart failure, severe liver disease, or chronic alcohol abuse. We should not use metformin. Some cationic drugs that are eliminated by the renal tubular secretion, they have the potential for interacting with the metformin by competing for the common renal tubular transport systems. So while we are using those cationic drugs like cimetidine, furosemide, and nifedipine, we have to adjust the dose of metformin. So adjustment of metformin is recommended in patients who are taking cationic medications like cimetidine, furosemide, and nifedipine. So only my reference is Goodman and Gilman's Pharmacology Because of Therapeutics, 30th edition. And thank you so much for your kind attention, and kindly share my lectures to your friends. Thank you. And next I will target very important drug of anti-diabetic agent, that is pioglitazone. Thank you. I will see you soon.